Hello, my name is Melissa Conup, and I will be presenting a case of chest pain with rash. This patient is a 55-year-old male who presented with chest pain for 2 days and skin lesions for 6 days. Initially, the chest pain was persistent, however, it became more intermittent over the course of the admission. The patient was afebrile at presentation, but did have intermittent fevers up to 38.2 degrees Celsius. In terms of exposures, the patient was camping 4 weeks prior and did notice a tick, but said it was not latched or engorged. There were no sick contacts as well. While the workup was still pending, the patient was empirically treated with antibiotics, including cefepime, vancomycin, clindamycin, and doxycycline at different times, but did not have clinical improvement with any. Other pertinent positives include shortness of breath, lower extremity edema, and generalized joint pain. Physical exam was notable for mildly tender, circular, erythematous but blanchable plaques on the back of the neck with similar but smaller papules on the arms and legs. Past medical history includes COPD, chronic hepatitis C, heroin use disorder in remission, and alcohol use disorder. Surgical history is hernia and hand tendon repair. And allergies include Bactrim or trimethoprim sulfamethoxazole. The patient does not take any medications and has no known family history. In terms of social history, the patient smokes cigarettes, drinks about a pint of whiskey per day, and has a history of heroin use, both IV and snorting, last used over a year ago. The patient lives with his girlfriend and roommate, and there's one dog in the home. The patient is a construction worker, and he's sexually active with one female partner. Our initial lab showed a BMP that was all normal. Our CBC showed an elevated white count at 18.3 with high neutrophils at 15.1. Our cardiac testing was also abnormal. Our BNP was high up to 2,400. Our troponins were high. Interestingly, they started to downtrend to 262, which is still elevated, and then they started to uptrend again up to 1,984. Our inflammatory markers, ESR and CRP, were both high. Cardiac testing was then done to further evaluate this chest pain, and it was largely unremarkable. Our EKG was normal, our CTA was normal, except for some mild mediastinal lymphadenopathy. Our transthoracic echo showed a normal ejection fraction, some mild to moderate LVH, and some mild tricuspid regurg, but overall is normal. And our cardiac cath showed no significant stenosis of the coronary arteries. So, this leads us to our differential diagnosis. In terms of cardiac diagnoses, we must include myocardial infarction as a can't-miss diagnosis as a cause of chest pain. However, our cardiac workup was not consistent with an MI. So, other possible causes of this chest pain with the troponin elevation still include myocarditis and Takotsubo cardiomyopathy. Infectious diseases could also explain this constellation of symptoms, including HIV, Lyme disease, blastomycosis, which is a fungal infection that can be found in Michigan, and syphilis. Other possibilities include sweet syndrome, porphyria cutanea tarda, which we know can be associated with hep C, and autoimmune diseases such as SLE, discoid lupus, or a form of vasculitis. So that leads us to our further lab workup. We did an autoimmune workup, and the only positive was SSA-Rho antibody. Our infectious workup was also only positive for hepatitis C, which we already knew about. There could be false negative results. However, these tests likely rule out most of our infectious and autoimmune possibilities. Therefore, we did a biopsy of the rash. The pathology showed a neutrophil-rich dermal infiltrate, and the cultures were all negative. An example of this neutrophil-rich infiltrate can be seen on the slide. This skin biopsy was the final piece of the puzzle and led us to our diagnosis of Sweet syndrome. Sweet syndrome is also called acute febrile neutrophilic dermatosis and is characterized by erythematous plaques, fever, and a neutrophilic infiltrate on histopathology. Supportive labs include leukocytosis with neutrophilic predominance and elevated ESR and CRP. Our patient meets all of these criteria. Sweet syndrome can have many causes. The classical or idiopathic form is associated with infections, including upper respiratory and GI infections, and hepatitis C. It can also be associated with pregnancy and autoimmune conditions. Sweet syndrome can be drug-induced, most commonly from granulocyte colony stimulating factor, all-trans retinoic acid, and azathioprine, but many others have been reported. It can also be malignancy associated, including solid or hematologic malignancies, but most commonly with acute myeloid leukemia. The pathogenesis is not well understood, but it does involve immune system dysfunction. Cardiac complications are reported in the literature, but they're rare. We did not do a heart biopsy to confirm myocarditis because that's invasive and not indicated. However, our patient's myocardial injury is most consistent with myocarditis, which can be part of sweet syndrome. So, the next steps for our patient included a workup for the etiology. SPEP and peripheral blood smear were negative for a hematologic malignancy, but given there was mediastinal lymphadenopathy on the CTA, we were still concerned about a solid malignancy. However, our CT chest, abdomen, pelvis was negative. We also know our patient was not taking any medications. So our presumed etiology is chronic hepatitis C. To treat sweet syndrome, you can use glucocorticoids. We prescribed a high-dose prednisone taper starting at 50 milligrams, which decreased by 10 milligrams each week. We also started prophylaxis for pneumocystis jirovecii pneumonia, given he's on these high doses of prednisone. The typical prophylaxis you may have heard of is Bactrim. However, if you recall, our patient has an allergy, so we used atovaquone. That wraps up this case. So here are my references, and thank you for taking the time to listen.